Buenas tardes a todos, bienvenidos a esta... A ver, voy a compartir pantalla. Bienvenidos, buenas tardes. Vamos a empezar con la presentación del doctor Charlie Teo. I think he is now with us. I would like to introduce Professor Charlie Teo, who is a very well-known world neurosurgeon because of the minimally invasive concept in neurosurgery, which is not just a technique, but a philosophy. I had the great opportunity to spend 2 weeks with him, along with a few more young neurosurgeons from different countries. And I learned how to minimize the size of the craniotomies, how to speed the micro-movement, never be tired and never be bored. I want to share an anecdote to let you know better Charlie. And I remember a day after 14 hours in the OR, after 5 difficult surgeries, when everybody wishes just to go home, Charlie wondered if we should go to a karaoke or a Korean barbecue. This is Charlie. This is his spirit, never stop. So now I go with, I open the presentation, and I with you can discuss or make questions about the issues. So Charlie, welcome.
Thank you very much. It's very kind of you. It's a great honor to be here and for that lovely introduction. Before we get started, I'd just like to say that I've enjoyed our relationship for many, many years with you and Ricardo, and it was great to have you in Australia. And I hope that this presentation gives some your viewers some idea of my philosophy on cranial neurosurgery. So before we get to it any further, I'm just going to share my screen now. Okay. So Sonia has asked me to talk about minimally invasive approaches and some tips and tricks. Hopefully I'll have about 45 minutes of didactic presentation, and then we can get into some question and answers and some feedback. So I like approaching my craniotomies bearing in mind 2 very important points: the entrance and the corridor. Traditionally, we've been taught that the larger the craniotomy, the safer the operation. So many of the old techniques were based around safety with a swollen brain, the ability to get in 2 or 3 suckers, the ability to control hemorrhage. And we felt that it was important to have a large craniotomy to do that. But a large craniotomy takes a lot of time. It creates a lot of morbidity. It causes blood loss, post-operative pain, et cetera, And my point is, why would you create an opening that big when really you only need an opening to allow in a small person? And what I mean by that is that many tumors and many approaches to pathology are deep to the surface. And if a lesion is deep to the surface, then there's no necessity to have a large opening. So this tumor, although very, very large, it's an olfactory groove meningioma that extends beyond the mid-pupillary line. It involves a sphenoid wing. It's a very large tumor, yet if you look at it, it's deep to the surface. And if it's deep to the surface, then you can access this through a very small craniotomy. So we managed to achieve a complete resection, even of this component here, the component on the other side of the sphenoid wing in the middle cranial fossa. And we managed to do that all through a small keyhole type opening through an eyebrow incision. This is in postoperative day 1, looking very good with a complete resection. Now that's completely different to some pathologies that require a large opening. And I'm talking about superficial lesions. Superficial lesions need a extensive craniotomy to expose the limits of that superficial lesion. And the perfect example of that, of course, are convexity meningiomas, or in fact, any glioma or any tumor that comes to the surface and requires exposure of the entire borders of that superficial lesion. So this was done through a large craniotomy. You can see here a large incision to expose all the limits, and a good outcome because we expose the entire limits of that tumor. Where do you place the entrance? So we've already discussed the fact that if it's a deep lesion, it can be a small craniotomy. If it's a superficial lesion, it needs to be a larger craniotomy. But where is it actually made? And this brings up the whole concept of the 2-point rule, or the long axis of the tumor. Now, most lesions aren't perfect spheres. They have a long axis. In other words, they're usually quite cylindrical. They can be multi-axial, but they usually have one major axis. Once you identify that major axis, you mark the point that is deepest to the surface, and the point that is most superficial or closest to the surface, and then you draw a line along that axis to the surface, and that gives you your ideal trajectory. Now, of course, we have been taught in the past to always make the opening where the lesion comes closest to the surface, but you can see that if I had done that with this particular tumor, it would have given me excellent access to a small portion of the tumor, but it would have given me very poor access to the majority of the tumor. Now, it's the majority of the tumor that you want good access to. So again, mark the deepest point, mark the most superficial point, bring that to the surface, and that's your location of your entrance. Here's the perfect example. In this axial cut, this lesion looks quite spherical. There is a long axis, but the long axis unfortunately takes you through the optic radiation, so that's not good. On the coronal cut, again, quite spherical, and the long axis here probably takes you through the contralateral hemisphere, so that's not good. But on this cut here, you can see clearly there's a long axis with the deepest part down here and the most superficial part here. And if you draw that line, it takes you through the superior parietal lobule. So with this thalamic tumor, although we could have approached it through 3 different trajectories, the ideal trajectory is along the long axis through the superior parietal lobule and probably through this sulcus here. We then position the patient so that the brain doesn't collapse into the corridor. We use frameless stereotactic guidance to help us pick that trajectory and pick the perfect positioning. And then we do a small craniotomy based on that trajectory, small corticectomy. Well, actually, in this case, we went down through the sulcus to get a complete resection of that tumor. I want you to take particular note also that we don't use fixed retractors, and we're not using fixed retractors here because I think fixed retractors contribute to the morbidity, and that has been shown in many different papers of necrosis underneath the fixed retractor. Plus, it also impairs your ability or limits your ability to use the natural elasticity and the natural movement of the brain to get into those corners or get into those areas that aren't necessarily in the long axis or the corridor. You can see here I'm now using the elasticity or the movement of the brain, the natural movement of the brain, to access those other areas that are not along the long axis. So I think it's pretty easy to see that if I used a fixed retractor here or a tubular retractor, it wouldn't be good in terms of the mobility afforded by not using retraction. And we'll just take you to the end of that video showing that we have now achieved a very radical resection. The brain doesn't fall in because we've picked the right positioning, and there is no necessity to use fixed brain retractors. And you can see here we've achieved a gross total macroscopic resection with a very good outcome in this patient. The next concept I'd like to talk about is the concept of the corridor. So if we could just reiterate, we have decided that the entrance needs to be large only if it's superficial, the lesion. We have ascertained that the location of the entrance can be determined by the long axis or the 2-point rule. And we've also ascertained that to position the patient in a position so that the brain doesn't fall into that corridor. Now, the concept of corridor is this, very simple. Would you rather walk along that corridor, which is cluttered and obstructed, or would you rather walk along that corridor where there is no cluttering and no obstruction? And that's what you've got to think about when you think about the corridor that you're going to choose to take to this, to get to this lesion. Again, by way of example, let's look at this petroclival meningioma. We can approach this through a transcranial approach. The long axis takes us to the retrosigmoid transcranial approach. But if we were to approach this transcranial, what are the impediments or hurdles in that corridor? Well, first you have to cut through the scalp, then you have to go through the calvarium, then you have to open the dura, and then of course you've got the vein of Dandy or the superficial petrosal vein, you've got cranial nerves, you've got the cerebellum before you get to the tumor. So the corridor from a retrosigmoid approach is fairly cluttered and obstructed by many of these different structures. The other approach is through an endonasal approach, again, still obeying the concept of the long axis or the 2-point rule. What are the impediments in the corridor here? Well, you have mucosa of the over the clivus, you've got the bone of the clivus, you've got the dura, but then you get directly the tumor. So in terms of impediments in the corridor, the endonasal approach here is a much better and much more efficient approach to this petroclival meningioma. This is just the operation to orientate you. We are now drilling out the Vidian nerve. This is the clivectomy. We are skeletonizing the right paraclival carotid. We've taken away the bone of the upper clivus to get access to the petrous apex. We are going to skeletonize the paraclival carotid even more so we can retract it laterally. Again, the more lateral the retraction, the more access we get to the petrous apex. We have now drilled out the clivus, we're drilling out the petrous apex, and the tumor is going to be right here underneath this bony opening. So what have we had so far? We've gone through mucosa, we've taken out bone, we've opened the dura, and we get immediate access to this petroclival meningioma. What you see here is the basilar trunk, some branches, the 6th cranial nerve going through Dorello's canal here. This is the meningioma. We've debulked significant amounts of this meningioma and we've devascularized it with this approach. We're decompressing the brainstem here. And again, you can see this beautiful trajectory from the contralateral nose through a clivectomy with retraction of the paraclival carotid without any cranial nerves, without any vessels, and without any brain obstructing our approach. And at the end, a complete resection of this petroclival meningioma. Here's the pre-operative MRI scan, the post-operative MRI scan showing a fat graft, tumor's gone. This is 6 weeks post-op. 6 years post-op, there is a small remnant that hasn't grown. This tumor in the cavernous sinus that is still present but hasn't grown. And we've got a patient who's done extremely well in good neurological condition. Now let's talk about some of the other minimally invasive keyhole approaches to tumors of the cranial cavity. I'm going to talk about keyhole calvarial approaches, One of the workhorses is the keyhole eyebrow approach. We're going to then talk about one of the standard approaches to the pineal region, the keyhole supracerebellar infratentorial approach, the keyhole pterional approach, and finally, the biggest workhorse of all, to the posterior fossa, the keyhole retrosigmoid approach. Okay, let's look at this multifocal GBM and how do we apply the minimally invasive keyhole philosophy to these tumours. Well, clearly this is superficial. We want to achieve a gross macroscopic resection. So the craniotomy on this side has to include the entire surface presentation of this GBM. The other tumour on the right-hand side is more difficult. It's deeper down, but it's not superficial and therefore does not require a large craniotomy. So for the right-sided lesion, we have a very small burr hole type craniotomy. And for the larger superficial left-sided tumour, we do a much larger incision to expose the entire surface of that GBM. So this is the right-sided approach to the thalamic lesion. We're going to open up the fissure. And again, this is just to demonstrate that this can be done through a keyhole, small craniotomy, no bigger than the size of about 2.5 or 2 centimetres in diameter. Small corticectomy, small sulcal opening, and preservation of the surrounding brain. And then this is the superficial lesion, much larger craniotomy, but good exposure of all the edges of that more superficial lesion. And again, at the end, a complete resection with preservation of en passant vessels and exposure of normal interface, normal brain. So preoperative scans, postoperative scans showing a complete resection of the deep thalamic lesion and a complete resection of the superficial multifocal GBM with a good outcome. And this is him doing weights 5 days after surgery. This is a butterfly glioma. And again, I'd like to impress upon you the deep situation or the deep location of this lesion. And therefore, a large craniotomy is totally unnecessary. This can be done through a small burr hole type craniotomy. And you can see a complete resection of the ipsilateral and contralateral portions of this GBM, all done through, again, a small straight incision behind the hairline, obeying all the principles of keyhole philosophy. This is another deep-seated butterfly glioma. You can see that there is extension on both sides, centered on the splenium of the corpus callosum. We, again, obey the principles, look for the long axis, carry the long axis to the surface, small craniotomy above the sigmoid transverse junction, and bearing in mind that we want to preserve, identify, and preserve the vein of Labbé. So a small incision, small craniotomy just behind the ear, and again, a complete resection of the ipsilateral and contralateral portions of this butterfly glioma. So at the end of the day, these are my tips and tricks. I use the QuickTone product to avoid eloquent cortex. I position the patient to avoid the use of fixed brain retractors because you don't want to clutter your small craniotomy, and you certainly don't want to use tubular retractors. And I encourage you to use the endoscope to give you angled visualization of those lesions that are multi-axial and require angled visualization and angled surgery. Just by way of demonstration, this is a multifocal GBM. You can see that we've taken out the GBM on this side with a very good response. And now she's unfortunately got recurrence in the right frontal area, right close to her central executive network. So how do we identify the central executive network so that we don't damage it? This is the omniscient technology, and the program is called QuickTone. You can see that many of the white fiber tracts are displaced by this lesion. But if you want to make sure that you don't damage cortical structures and subcortical structures, we now have identified the central executive network in pink, the salience network in blue, and the somatosensory network in yellow. The green network, of course, there is the default mode network. And again, we see now that the entrance to this GBM is through this safe zone here in front of and behind central executive network, in front of the somatosensory, superficial to salience, and well away from DMN. Complete resection, complete resection. The principle of operating perpendicular to the floor means that the brain doesn't fall in. So if you were to operate with a patient angled like that, then of course you're going to need to use self-retaining retractors so that the corridor is not obstructed by a brain that falls into the corridor. And the way to do that is to position the patient so that it is perpendicular. The long axis is perpendicular in all three planes. Now, let me show you how we do that. Here's a patient where the long axis is along this trajectory, this trajectory, this trajectory. But you can see that if I were to operate with the patient position like this, once I created my corridor, the brain would fall in. That would necessitate me using a self-retaining retractor, and that would clutter my instruments and cause what I believe to be more morbidity than is necessary. So what do? I position the patient so that the trajectory is perpendicular in all three axes. And in that way, you can see the brain won't fall in, you won't need to use any retractors, and you can minimize morbidity and swelling from the operation. So again, here's the long axis. We position the patient so the patient was straight up and down, and again, managed to achieve a gross total resection. The third principle is generous use of the endoscope. Now, we all know that these mesial lesions are very difficult. They're difficult because they extend out more laterally. So an ipsilateral approach here doesn't give you good exposure to the lateral portions of this tumor. And therefore, we often look to the other side to do a contralateral approach. But I think you can see that if we did a contralateral approach on this patient, we'd be going straight through these very important bridging veins, and you can't do that. If you can't go contralateral, then again, we use the QuickTone product to show us if this cortex right here is eloquent, and it looks like it's not. So the principle here is to go ipsilateral, but to use angle view to reach out laterally. Here's the operation. So just to orientate you, this is the left side, this is the midline, this is the dural flap against the superior sagittal sinus. This is a very important bridging vein that's probably the Rolandic vein. So what we do here is we achieve as great a resection of the glioma as we can with the microscope without damaging the overlying cortex and without damaging this important bridging vein. And I think you can see here that I'm stretching that vein considerably. And I'm starting to think now that maybe I should be using angled visualization. At this stage, I'm really pushing on the brain, and I start to think that maybe the brain is being traumatized. You can see that that vein was certainly being compromised. So what I'm going to do now is use angled instrumentation with angled visualization using a 30-degree endoscope. This is a sucker bipolar. So this is a hybrid instrument that has two functions, suction and bipolar, which I can hold in one hand. And in the other hand, I have a 30-degree endoscope looking out laterally to identify tumor and brain interface. And I'd like you to appreciate from this video that the differentiation between normal brain and tumor is actually better with an endoscope than it is with the microscope. So we're looking here for the typical appearance of normal brain with the petechiae. We haven't seen it yet. This is too bright and too sort of glossy. This is clearly low-grade glioma. We still haven't seen the normal brain interface. We're sucking and bipolaring with this angled instrument. So this is called the Kirwan bipolar sucker, spelled K-I-R-W-I-N. I have no financial interest there. It is malleable, disposable, and has a bipolar component at the end of the sucker, so you can bipolar and suck with the one hand. Okay, we still haven't seen the interface yet, but in a minute you're going to see it. I just might hurry that forward a bit. Okay, here we go. This is normal brain with a normal petechiae appearance. And this is still a bit of glossy brain tumor. And again, once this is out, you'll see the normal appearance of normal brain. Very nicely seen with the endoscope and very nicely resected with this angled instrument, so we don't have to damage that bridging vein and we don't have to damage the overlying cortex. You'll see that my incision is quite long because you've got to make sure that you don't damage those bridging veins. And this is a pre-op scan showing the lateral component of this tumor and showing that we managed to reach out all the way out here without damaging the overlying cortex. And again, a complete and radical resection of this low-grade glioma in a very difficult location, preserving the bridging veins and the overlying cortex. The keyhole eyebrow is one of my favorite operations. It's the workhorse to the anterior cranial fossa, middle cranial fossa, paracella, supracella, cella, and even brainstem areas. Here's one such case. This is a midbrain tumor. We're going to do a subfrontal approach through the opticocarotid window to take out this midbrain lesion. It reaches a long way high up. And again, we're going to get that through the using endoscopic guidance. So again, here's the approach, subfrontal, opticocarotid window. Here's the incision. We very rarely have to carry that incision beyond the hair-bearing area, but I prepared just in case. Scalp incision, pericranial flap inferiorly, burr hole in the keyhole area, small craniotomy, drilling of the inner table and drilling of the orbital protuberances to achieve a better view of the skull base, opening of the dura, subfrontal approach, carotid, opticocarotid window, third nerve, posterior clinoid. These are the windows through which you gain access to the midbrain and brainstem. Carotid bifurcation, M1, A1, and tumor is going to be down here, opticocarotid window here. So we've got many different windows through which we can operate. But remember, it gets pretty dark down there. It's a long way in. So what we use is the endoscope to improve our illumination, improve our magnification, and improve our angled views up into the subthalamic region. What we have here is normal brainstem, and what we have here is tumor. And the interface, again, I hope you can appreciate the interface between tumor and normal brain is even better with the endoscope than it is with the microscope. And here's the patient, complete resection. This was about almost 20 years ago, and curative resection with a good functional outcome. Just to show that the eyebrow is a very versatile approach, because this was a very difficult skull base meningioma. It was recurrent, atypical, post-radiotherapy, involving the entire ICA trunk, bifurcation, M1 and M2 branches, embedded within the tumor. But again, it's deep to the surface. So the philosophy of minimally invasive neurosurgery is that if a lesion is deep to the surface, you only need a small opening and you can get just as good access and just as good control of vascular structures using a nice keyhole eyebrow approach with a complete resection and a good outcome. This is the incision they made at St. Elsewhere's at another hospital. That was for the biopsy. And this is the incision we made through the eyebrow for a gross total resection. The eyebrow approach is cosmetically very pleasing. You can look at all your patients, even long-term, and see that it's impossible to tell which side the operation was on. In some patients, they get a little bit of wasting of the temporalis, like this patient right here, but in most cases, you can't even tell which side they had the operation. Here are my tips and tricks for the eyebrow approach. The fish hooks that you use to retract the scalp should be wrapped around the handle of the Mayfield, and that gives you very good superior retraction of the scalp, which is important to make sure that your craniotomy is not too small. To make the approach even more skull-based, make sure you drill off the inner calvarial table and the protuberances of the orbit. The endoscope is an invaluable tool with the eyebrow approach, and you've got to make sure that your closure is meticulous and neat because it's so visible and it's your visible signature of that operation. If time permits, I can go through the operation for you. I can go through step by step, but I'm not quite sure we'll have time. I'll leave that up to Sonia at the end if you want me to go through that video. Let's talk about the keyhole supracerebellar infratentorial approach. I'm just looking at the time. Okay, so this is a mixed germ cell tumor of the pineal region. If you look at the long axis, it takes you to the infratentorial space. So what we're going to do is a paramedian infratentorial approach. It's about 2 fingers breadth away from the midline. We blue line the inferior border of the transverse sinus. It's a straight incision. And the reason we do the paramedian approach is I want you to think about this. If you do a midline approach, then the trouble is you won't be able to see your target because of the superior vermis. If you do a paramedian approach, you can see the target because you are away from the superior vermis. So the approach is a paramedian approach, not a median approach, so that you don't have to retract those elevated midline structures. Here's the straight incision. This is top, this is bottom. Here's the blue lining of the transverse sinus. A small craniotomy, about the size of about 2 centimeters in diameter. A flap against the transverse sinus. That will then expose the cerebellum. You won't get bulging of the cerebellum because it's such a small craniotomy. And indeed, you'll start getting CSF egress as soon as you open the dura. CSF starts coming out from the subdural space. And when you start retracting underneath the tent, above the cerebellum, you'll get good CSF egress. And if you want more CSF egress, then you can go all the way to the cisterns to open up the cisterns as well. In this case, it wasn't necessary. Oh, yes, it was. Okay, so here we are opening the cisterns to let out CSF. And then we're going to go through the tent. If we want to go through the tent to a supratentorial approach, we can just open the tent here. In this case, it's a pineal lesion, so we don't have to open the tent, and we're just going to stay below the tent and above the superior surface of the cerebellum. The arachnoid here is often very opaque. You've always got to assume that there are going to be large veins beyond that. These smaller vessels coating the surface can be sacrificed with impunity. And again, if the free edge of the tent starts getting in your way, then you can open that tent without any concerns. So here's the lesion. I'm just going to hurry this video along if you don't mind. We're going to take out what we can using microsurgical technique. This was a very tough tumor, stuck to a lot of structures. Okay, so we think we've achieved a pretty good resection. We think this is normal pulvina. And so what we're going to do now is put the endoscope in and make sure that we have achieved that complete resection. Here's the endoscope going across the surface of the cerebellum. Here's the tumor resection. Here's the tumor bed that we looked at. There's the third ventricle there. This is the back of the pulvinar. And it looks like a good resection. But now we're going to put the 30-degree endoscope in and look around and look what we find. The 30-degree endoscope shows that we've actually left a significant portion of tumor well above our angle of view. And this is tucked in behind the occipital lobe, tucked in behind the large veins above the brainstem. So you can see here that this was impossible to see with the microscope, but very easily seen with the endoscope and angled visualization. And then we take out that final component. And now we can place the endoscope in and see that we've now achieved a complete resection. This is the back of the third, pulvina, internal cerebral veins, vein of Galen up here somewhere, and a complete resection of that lesion, looking around the corners using the 30-degree endoscope. No fixed retraction on the cerebellum, no fixed retraction on the tent. Pre-op and post-op showing again a complete resection and again a good outcome. These large lesions, we don't want to take this from a lateral approach because then you damage the optic radiation. So a beautiful approach is the infratentorial, supracerebellar, transtentorial approach, and you can open this tent as widely as you like to give you good access to this supratentorial meningioma. And again, here's the wide opening of the tent to access that lesion, complete resection, complete resection, complete resection. And again, I'd like to show that there are no footprints. Here's the preoperative scan on T2 and the postoperative scan showing no footprints, no damage to the superior surface of the cerebellum. My tips and tricks here are position the patient supine. So you don't have to do this lateral decubitus, and you certainly don't have to do it prone. We do this in the supine position with the head turned maximally away from us and a lot of reverse Trendelenburg to reduce some of the swelling and engorgement of the veins. Always make sure you see the blue line or the inferior border of the transverse sinus before you open the dura. And please feel free to sacrifice any of those bridging veins with impunity. Now, some of these bridging veins are very large, and you start thinking, gee, am I allowed to sacrifice those large bridging veins? And the answer is yes, you can sacrifice every one of them without any concern whatsoever. Let's now talk about the keyhole pterional approach. This is the way I was taught to the keyhole pterional approach. I was taught to make the incision just in front of the tragus. But in fact, if you look at your anatomy, you'll see that you don't have to make your incision this far back. 97% of cadavers, the facial nerve comes in front of the midpoint between the tragus and the outer canthus. So you draw a line between the outer canthus and the tragus, you find the midpoint, and in the majority of patients, the facial branches to the frontalis travel in front of that midpoint. So what that means is that you can bring that incision more anterior, which allows you to, again, minimize the length of it because you don't have to make your incision this far back. This is your danger zone. This is your safe zone. And again, so now we've modified our mini pterional. So the incision is just behind the hairline with good preservation of the frontalis branches of the facial nerve that travel in front of the midpoint between the tragus and the outer canthus. This is an example of how we use the mini-terional. In this particular case, we want to do well, in this case, the temporal lobes involved, we want to do a trans-Sylvian approach. This patient was biopsied at another hospital. We didn't do that. Look how big their incision was just for a biopsy. And this is our incision for a complete resection. Okay, so here's a left insular glioma involving the temporal lobe. So we're going to take the temporal operculum and temporal pole, which will give us access to the insula. And we're going to do it all through this keyhole mini-terional craniotomy. So to orientate you, this is the front, the back, the skull base, and the top of the head here. Now we're doing a temporal lobectomy. We're making an incision in the STG, superior temporal gyrus. We've already exposed the insula here. So this is the temporal operculum going. These are the branches of the MCA. This is the bulging tumor of the insula. We do our temporal lobectomy, which has this tumor all through this temporal lobe here. We then amputate the temporal lobe at the temporal stem. There's the skull base. So we've taken off the inferior extension of this insular glioma that extended through the temporal stem into the temporal lobe. We now take out the insular component, maintaining the branches of the middle cerebral artery. So here we go. Here's more tumor being removed to expose the bulging insula, and we're going to be operating through these windows. There's the rest of the temporal lobe, and now we start finding the windows through which to operate. Remove the insula. This is just completing the temporal lobectomy. And okay, now we're going to start taking out the insular component. We identify the caudate head, identify the LSAs, lenticulostriate arteries. There's the caudate head. You can see the sort of little white petechia, the white sort of squiggly lines and a yellow background. We've skeletonized the MCA and we've operated through these windows in the MCA branches. And we, again, preserved all the MCA branches, complete resection now, temporal lobe gone, insula gone, and MCA trunk preserved, all done through a small craniotomy. Here's the post-op scan showing the temporal lobectomy. The insular component is completely gone. We've maintained and preserved the frontal operculum. Again, pre-op and post-op. And day 2 after surgery showing a good patient in good neurological condition. Again, here it is, branches of the MCA, preserved, insular component gone, maintaining the integrity of the caudate and caudate body, and all done through a very small incision just behind the hairline. Here's my tips and tricks. I double breast my opening. In other words, the opening in the scalp does not correspond with the opening in the temporalis fascia. It's a nice little trick because it helps reduce the incidence of CSF fistula or CSF leakage. You get a very nice closure. So a double-breasted opening. I split the muscle, I don't cut it. And that again reduces the amount of dead temporalis and wasting of the temporalis, which gives you a much better cosmetic result. And always be cognizant of the sphenoid wing. What I do when I do my dissection through the muscle is I put my finger on the sphenoid wing, and I'm always cognizant of where that sphenoid wing is, because if you're not careful, sometimes you can make your craniotomy too temporal or too frontal. So you've got to feel the temporal, sphenoid wing, so you can turn your craniotomy exactly where you want it, either frontal, temporal, or straddling the sphenoid wing. Finally, now let's talk about the keyhole retrosigmoid. I think I'm running out of time. Yeah, I've only got about 5 minutes, but we'll do this quickly. So again, it's a small craniotomy because most CP angle tumors are deep to the surface. I'm talking of things like acoustic neuromas. So this is a nice video showing my approach. I just want to show you that, that approach. Oh, sorry. Okay, so this is my incision. Now, I know that many of you were taught this incision, up and down, or C-shaped, and you were taught not to make them horizontal, because if you make them too horizontal, you devascularize the scalp. But remember, these are keyhole craniotomies requiring small incisions. So this incision is shorter than 3 centimeters. So what we do is we identify the landmarks for the sigmoid sinus, transverse sinus. We mark out where our craniotomy ought to be, and this is about the size of your thumbnail. It's a very small craniotomy, about 1.5 centimeters in diameter. And we make the incision so that the arms of the self-retaining retractor don't get in your line of sight. Now, if I made the incision like this and put a self-retaining retractor in there, then of course the arm of the self-retaining retractor will obstruct my line of sight. So you figure out your line of sight, you make your incision in line with the line of sight so that the retractor doesn't get in your way. And then again, it's a small craniotomy thereafter. Small craniotomy, small dural opening. This is the dural flap against the sigmoid sinus. This is the transverse sigmoid junction. We're now letting out CSF. And again, time is not on my side. So here's the acoustic. I just want to show you that you can still get a drill in there. This is a very small craniotomy, about the size of your thumbnail, but you can still get a drill in there, no problem. That's me drilling out the porous and taking out the tumor, preserving hearing, preserving the facial nerve. And at the end of the operation, we put the endoscope in just to make sure we've got a complete resection. And to make sure that we haven't drilled any air cells when we drilled the porous. Superior petrosal sinus, tent, posterior wall of the petrous bone. Oh, and here we go. Look, I've drilled a little hole in the air cells. So we're now going to plug them up. So again, the endoscope serves a very important role here of identifying holes in the air cells or tumor in the apex of the IAM. And a complete resection, good outcome. This is a large, again, they're deep to the surface. Just because it's a large tumor doesn't mean you need a large opening. And just some more CP angle tumors, all done through this mini sort of approach. Here's a brainstem glioma. Small incision. Tips and tricks here, position the supine, patient supine without elevating the ipsilateral shoulder. So it's very tempting that if they've got a stiff neck and you turn the head to the other side, if you can't get enough turn, people put a bolster under the shoulder. But if you put a bolster under the shoulder gets in the way of your line of sight. You're meant to push the shoulder down, turn the head, and then if you really do need to rotate the patient more, we rotate the entire bed, but we don't elevate the shoulder. Sacrifice any bridging veins. You can even sacrifice the vein of dainty if you like. We try and preserve them, but please don't worry if you have to sacrifice it. And again, generous use of the endoscope so you can look into the porous and to make sure you've got a complete resection. So I've taken you on a very quick trip through minimally invasive keyhole approaches. I hope that I've relayed to you some of my basic philosophies of how to localize the entrance, how to pick the right trajectory, how to pick the right corridor, and then how to manipulate the tumor so that you can get a complete resection, not only using microsurgical technique, but endoscopic assisted resection using angled instruments and angled visualization. Anesthetic agents at lower ICP, single shafted instruments, more accurate preoperative imaging, better illumination, magnification, and angle views have allowed us to reduce the cranial openings, thereby reducing collateral damage, reducing operative times, and certainly reducing post-op complications. Keyhole approaches do require a leap of faith. If you're used to doing a big craniotomy, it does evoke quite a bit of anxiety when you do a small craniotomy. You think you're getting into trouble. You just have to take my word for it. You won't get into trouble. If the lesion is deep, you only need a small craniotomy and you can still get 2 or 3 suckers in there if you have to. I've hit the carotid artery through an eyebrow approach and I can still control it just as well as if I had a large frontal craniotomy. So it is quite daunting. It is quite anxiety provoking, but it can be done. And I would urge you to start with small lesions, easy lesions, and build up your confidence. It is a new skill set for sure. And you certainly have to become adept at endoscopic assisted surgery, which means you have to have the right armamentarium. It's not good enough to look around corners. You need to be able to operate around corners. And that means angled instrumentation as well as angled views. Thank you very much.
So thank you very much for this great presentation, Teo, as always. So we have a few questions. The first question is from José Luis Gelsalud, who is the secretary now of our society. And he thanks you for the presentation, and he wanted to know, he said that sometimes the neurosurgeons are afraid to postoperative edema with small craniotomies. And what do you think about that? You have more postoperative edema after small craniotomy. Do you think this is an issue?
Sorry, I didn't quite get the question. Sonia, can you just repeat it again?
He's asking about the problem of edema with a small craniotomy.
Oh, okay, yeah, good. Okay, so it is, look, one of the fears of a small craniotomy is that the brain's going to bulge out and that you won't get the same conditions. I just have to reassure you that I've been doing neurosurgery now for 35, almost 40 years. And when I first started neurosurgery, you're absolutely right. We had no propofol. Most anesthetic agents would cause swelling of the brain. Conditions were always poor. And I was always happy to do a large craniotomy to allow more relaxation, I guess, or more decompression of the brain. That just doesn't happen these days. It just does not happen. No matter how much edema you have, with anesthetic agents that reduce the swelling of the brain, with diuretics, with positioning of the patient, with egress of CSF, with a lumbar drain if necessary, and that's very rarely necessary, but if necessary, a lumbar drain, you can get good conditions. One of the other ironical things about a small craniotomy is that it gives you time. When you do a big craniotomy and there's a big swollen brain, the brain comes herniating out and you start tearing the cortex and it starts bleeding and you panic a little bit and you retract the brain and it's just one problem after another. And I've been there, we've all been there. With these small craniotomies, they don't herniate out. The brain doesn't herniate out. So what that allows you to do is actually take your time. So I elevate the patient more, I maybe give a little bit of Lasix or mannitol, I sit back and relax a little bit, I score the PIA and let a little bit of CSF out, maybe we hyperventilate, maybe we give some mannitol, but the bottom line is you don't get those brains herniating out through the craniotomy anymore because it's so small. And in fact, ironically and paradoxically, there are less problems with a small craniotomy than a large craniotomy. So I know it's daunting, and I know you're worried about the edematous swollen brain, but believe me, it's not a problem. With good neuro anesthesia, it just is not a problem.
Okay, so yes, this I think can answer the second question that I have, and he's from Manuel Revuelta. He was asking about the indication for using a lumbar draining. Are you using lumbar draining?
Lumbar drain, like, yeah. So if I know that I can't get to CSF spaces for a significant period of time, in other words, that olfactory groove meningioma, for example, I knew that with that case, it was such a big lesion that there was going to be a lot of intracranial hypertension, and I wouldn't get to the CSF spaces until I took out at least half of that tumor. In that situation, I used a lumbar drain. So if you can get to CSF spaces and basal cisterns or ventricles first before you attack the tumor, then don't use a lumbar drain. But if the tumor is stopping you from getting to the CSF spaces and the basal cisterns, then unfortunately, yeah, sometimes you need to use a lumbar drain. But with all the tumors that I do, which is, easily 350 tumors a year, I've done 11,000 brain tumors. The number of times I've used a lumbar drain, I can count on one hand, really one hand. I've never used a lumbar drain definitely not more than 5 times in my lifetime. It's very rare you have to do it.
Great, thank you. The next question is that are you using minimally invasive surgery for recurrent tumors?
Oh, absolutely. And I've got a whole talk on that because a lot of people think that, they've had a big incision with the first operation. With recurrence, we've just got to open the first incision. That is not the case. I've got this whole talk showing these big question mark incisions and again, using the philosophy of the trajectory, the long axis. We basically ignore the first incision and we can make small incisions either along the same line as the first incision or completely disregarding it. These incisions are so small, they very rarely compromise the scalp blood supply. So yeah, with recurrent tumors, absolutely. The small incisions, small craniotomies, you don't have to reopen the initial surgery. Okay.
And also I have another question. You said that it was important, the skin closure. And do you think is it important also to do a very tight dura closure, a watertight dura closure, or is not that important? What do you think?
Well, in general principles, I'd like to do a watertight closure of the dura. General principles. I must say that if the dura is tattered and it's going to increase the length of the operation by a significant amount of time, they haven't had previous radiotherapy, it's supratentorial, you haven't opened the ventricle, they're not on steroids, then I don't necessarily close the dura. If, however, it's a retrosigmoid approach or an eyebrow approach, where CSF leakage can be a huge problem, either cosmetically or with CSF fistula, I go to extraordinary lengths to close the dura. So there's nothing worse than having a dural leak from an eyebrow incision because it gives you a big swollen eye. They walk around for weeks with a big swollen eye and the eye closed. And when people say to them, oh, who did your operation? Oh, Dr. Teo did my operation. Oh my God, Dr. Teo, what a terrible operation. You've got a big swollen eye. Conversely, if you do a nice closure, a nice neat closure, no swelling, it's your signature, it's your advertising if it's good. And it's bad advertising if you leave a lot of swollen CSF. So there are some operations like a retrosig or previous radiotherapy and open the ventricle or an eyebrow incision where I'll go to extraordinary lengths to close the dura and get a watertight closure.
All right. Okay, so thank you very much. I think we don't have any more questions. Congratulations again for your nice presentation. And I'm very happy to share with you these minutes and this knowledge.
Thank you very much, Johnny. And thank you very much for the invitation. And sorry I couldn't give the presentation in Spanish. I actually can speak a little bit about poquito español, but it's too It's very bad Spanish.
No, it's wonderful, Teo.
Okay.
Okay, thank you.
Pleasure.
Bueno, muchas gracias a todos por vuestra participación en este meeting. Por favor, me piden que contestéis ahora a una encuesta que van a pasar después de la presentación. Y bueno, muchas gracias por estar aquí un viernes tarde. Un abrazo a todos. Hasta luego.